Hi, and welcome to SpondyCast, where we bring together the best medical minds, thought leaders, scientists, patients, and caregivers to inform and inspire the spondylitis community. I'm your host, Jill Miller, living my best spa life, knowing that how we meet today has the power to change everything going forward. Please note that the information provided in this podcast should not be considered medical advice. We do encourage all listeners to consult their healthcare professionals for medical concerns. Thank you for listening, and we hope you find our discussion today enlightening. Hi, and welcome to SpondyCast. Today we're going to talk about pain when it persists and understanding the brain's role in spondyloarthritis. Our guest today is Dr. Mohamad Bittar, Assistant Professor of Medicine at Oregon Health and Science University, and SAA's 2025 Early Career Investigator Award winner. He joins us to discuss his research on pain mechanisms and brain connectivity in people living with axial spondyloarthritis. His work explores why pain can persist even when inflammation appears controlled, revealing how the brain and nervous system shape what patients feel day to day. Dr. Bittar explains how this emerging science could lead to new ways to understand, manage, and treat chronic pain, bringing fresh hope for improved comfort and quality of life. Let me tell you a little bit about Dr. Bittar. He earned his medical degree from the American University of Beirut, then completed his internal medicine residency at Indiana University School of Medicine and Rheumatology, and fellowship at Baylor College of Medicine. He also earned a Master of Science in Epidemiology with a focus on clinical investigation from the University of Tennessee Health Science Center. Dr. Bittar has special interest in axial spondyloarthritis and ankylosing spondylitis. He directs the Axial Spondyloarthritis Clinic at Oregon Health and Science University in Portland and is the chair of the Education Committee and member of the board of directors of Spartan, which stands for Spondyloarthritis Research and Treatment Network. He is currently focused on studying the pain mechanisms in axial spondyloarthritis, and we are excited to have him here today. How are you, Dr. Bittar?
I'm good. Thank you so much for the generous introduction, and I'm very happy to be with you. Thank you for inviting me.
No, I love it. I love that you're here. We were talking in the green room about uh, how fun it has been to watch your career unfold. And I want to begin by congratulating you on receiving the Jane Burkell SAA Early Career Investigator Award. It's a fun accomplishment for you, but it's just as fun when we get to give it out at SAA. But I would love to hear from you a little bit about what this award recognized for you and how it relates to your ongoing research on pain mechanisms and brain connectivity.
Yeah, first, I would like to thank SAA for the award. This is a major milestone, and this is a big thing for me, to be to get this award. So it was a very important moment in my career, and I've been working with SAA for a long time. And yes, I just said that you're seeing me how my career is growing at this point, which is amazing. We've been working for years now with Spartan and with SAA on spondyloarthritis work. So I'll tell you a little bit briefly about why I'm working on chronic pain research. This is for the most important thing is this is one of the highest research questions of importance for patients. So what we did is we did a survey with the SAA. I worked with SAA on surveying patients with axial spondyloarthritis. And I asked, what is the most important research topic that you would like us to work on? Because we always, as providers, we try to think about what we want to gain out of the research. But sadly, a lot of times we forget about what patients need. So actually that I wanted to do something different. And I wanted to ask patients what do they think that we need to focus on in the research. And guess what? The number one research topic was chronic pain, and it was answered by I think more than 75% of the respondents.
Wow.
And this furthered my interest in the topic. Of course, I had interest in the topic of chronic pain, but this solidified that, okay, yes, we need to be working on this field. And of course, I explored different ideas in chronic pain. And thankfully, when we submitted the award, the SAA, they liked the proposal, and they gave me the award. So I'm very thankful for that, and I'm happy to talk to you more about it.
Yeah, that's amazing. Because so many people who live with axSpA also wonder why the pain doesn't go away when the active inflammation seems to be gone, right? And why does that happen?
This is a $1 billion question.
It might be
I
more.
maybe more. I wish we had the answer, but we're working on getting there. This is my main focus and the project that we're doing now in order to understand the mechanism behind the pain. Because this is very important to know that pain is a symptom. And I always talk to my patients about this. Pain, it's a symptom that there is something going on that we need to know where it is coming from. So, as much as we would like to say, okay, this is inflammatory pain, this is mechanical pain, but at the end, it's a symptom, it is not a diagnosis. So, I always try to decipher this into what we call phenotype pain. Phenotype pain, it means that we know where it's coming from, the etiology or the origin of it. There are three main phenotypes of pain. One is called nociceptive, one is called nociplastic, and one is called neuropathic. Nociceptive, it's whenever there is active inflammation or active trigger causing this pain. This is what starts in most patients with ankylosing spondylitis, axial spondyloarthritis, is when there is an active inflammation, it triggers a nociceptive pain. And we will talk a little bit more about the relationship with the brain. How does this relate with the brain? The other one is nociplastic pain. Nociplastic pain, it means there is pain, but we cannot identify a trigger. And by meaning we cannot identify a peripheral trigger, such as there is no active inflammation right now, or I'm not seeing an active insult to the joint to be causing the pain. This is nociplastic. And neuropathic is anything that affects the nervous system. For example, if there is a compression on the nerve or pushing on the nerve or so on, this is neuropathic pain. It's important to know the difference because the treatment is very different between those three different phenotypes. Sometimes our patients might be having a lot of active inflammation, and this is what happens sadly when patients have a delay in the diagnosis because they have ongoing inflammation, no one has detected it, and they have nociceptive pain that is being treated as a different type of pain. Of course, if
Oh.
yeah, this is at the beginning when patients are not diagnosed, when they are getting treatment that do not really work on the inflammation. The pain is there, it's going to get worse, and it might trigger other types of phenotypes. Because what we think is that it starts as an inflammatory nociceptive pain, and then it triggers or induces something nociplastic pain, which is non-inflammatory pain. That's why we always get back to the start, which is we need to capture the disease as early as possible, and we do not want it to be delayed in diagnosis. Of course, I can talk for an hour, but I want you to ask me
Yeah.
maybe directed
Yeah.
questions so I can
Yeah.
try to answer. But I have a
Uh,
lot of information I would like to share with you.
no, that's really interesting. I mean, I think it is this cycle that many of us have been stuck in. Uh, and and then we won't talk about it today as much, but then you throw fatigue in there, right? And then you try and get yourself out of the valley of despair in the fatigue world. No, it's really that it's making me think many years ago I listened, it was probably 2018, listened to somebody at a Spartan, I think it was Spartan, it was in Colorado. And I remember, if you remember Lauren used to run Spartan. Uh,
Lauren?
yes, thank you.
Yeah. Yes.
And they had a psychologist talking about this cycle, this chronic cycle that we get into, and if we can diagnose early on, we can prevent the acute from becoming chronic. And that was, you're like flushing it back to me because that was the moment I remember thinking, oh, this is why we have to, why SAA has to exist and like why we have to grow the grow the ability to research and deliver better solutions for the people with this disease.
Definitely.
Okay, so very exciting. Okay, let's talk about our brains. Uh, how does our brain actually process pain? And how can that process change over time for someone living with a chronic condition like axSpA?
Very important question. So the brain plays a big role in pain processing. Regardless if it's nociceptive, nociplastic, neuropathic, it will pass through the brain. So what we have is we have peripheral nociceptors. These are receptors of that sense pain in the periphery, such as in the hand, in the back, or anywhere in the body. So these nerve endings, they sense the pain and they send a stimulus through what we call ascending pathways. The ascending pathway go from the periphery to the spine and then to the brain. And then in the brain will process this signal between different parts of the brain, and then it will recognize that there is something that's not okay. And then the brain will send what we call a descending inhibitory signal. This descending signal, it's an order from the brain to inhibit the pain. And that's how the pain gets controlled. Of course, we're talking about when everything is working perfectly fine, you know. Um, a little taking a deeper look at the brain in specific, there are different locations in the brain. There is something called salience network, and there is something called default mode network. Default mode network is active when we're not doing anything. When we are relaxed, it is active. But when there is an insult to us, this should be inhibited. So, for example, when there is something hit me on my hand or in my back or so on, I'm feeling pain. So, this default mode network should get inhibited so it can let other parts of the brain, such as the salience network, to process the pain signal and to inhibit it. So, if you can see there, we have different stages where the signal is being processed. The first stage, which is the going up, ascending pathway from the periphery to the brain through the spine. And then there is in the brain itself the connection between the different parts of the brain. And there is the signal that should inhibit that's going down from the brain to the periphery. So, where do we have alteration in the processing? It can be at any of these locations. If the ascending pathway, the one from periphery to the brain, is becoming very active, it means it's facilitating the sense of pain going to the brain. And this happens a lot when patients have active inflammation, like the nociceptive. When they are first, they
Right.
have active inflammation. In the brain itself, if the signal reaches the brain and the areas in the brain are not connecting to each other as they should be, again, there will be disruption of the signaling of the pain pathway. And what our theory and what we showed in our pilot study that we just presented at ACR is that patients who have axSpA, who have chronic pain, the default mode network, instead of being inhibited with a stimulus, it actually gets activated. So that means for this default network, instead of becoming inhibited, it will be active and it will continue to focus on the experience of pain. And that's why the patients will be in a cycle of chronic pain. They're fixating on the chronic pain sensation and they cannot inhibit it. And the third location, which is the descending inhibitory pathway, the one that's going down from the brain, this in most patients who have chronic pain, this is not working as it should be. It should be inhibiting the pain, but it's not. So it's not working. It's less than it should be working. That's why the pain is not inhibited. So we have three different places in the nervous system where it can be affected, and this could be precipitating very likely the chronic pain experience that our patients have.
That's so interesting. How do you measure that?
That's a great question. I like your questions, Jill. Very important questions. So we are doing different types of procedures. Sadly, these procedures are not currently available to be used clinically, like not in the market, but these are more in research at this point. And thanks again for the SAA for supporting our work on it. We have the procedures that we do at bedside, such as what we call them quantitative sensory testing. Quantitative sensory testing, we have different modalities. One is called pressure algometry, where we apply certain amount of pressure using an algometer, and this gives us actually numbers. We know what we're working with. It's very accurate. It's very accurate numerically, I mean, and it tells us about the ascending and descending pathways. We can measure that. There is something called conditioned pain modulation, where we measure these pressure thresholds, but also we apply a stimulus, which is a cold stimulus. We ask the patient to put their hand in cold water, 10 degrees Celsius, and we measure the thresholds of pain before and after using the pressure algometers. This will tell us about the descending pathway if it's working or not. And also we do something called temporal summation where we do, it's a pinprick, it's a pen where we do multiple pinpricks on a specific location in the body and we measure the pain before and after. This tells us about the ascending pathway. And lastly, we are doing something very important, which is functional imaging of the brain. The functional imaging of the brain, it will tell us about the function of the brain with patients who have chronic pain and patients, how do they respond to a stimulus, a painful stimulus, how their brain is responding. And that's how we are measuring it.
That's I wondered if you were doing imaging. But the it's ergometer. Is that what it's called?
The algometer is for
Okay.
the pressure that's done at the bedside.
I'm gonna have to do some research there just for fun. Uh, okay, the brain and the body. So we know a little bit about what's going on in the brain, and I probably should couch all of this in saying we're just beginning to understand this, right?
Exactly. We're just beginning to understand that, and we are planning to implement very new techniques and technologies to look at the brain that have no one has done it before in axial spondyloarthritis.
That's amazing. So the brain body, as they communicate pain signals, what have you learned that can help patients sort of make sense of what they're feeling every day?
That's again very important question. So again, how I think about it is I think about it in the different pathways. Is it up? Is it down? Or is it in the brain? Because that will help me make the next decision about how to help my patient. And of course, Jill, we always need to mention that it's always a shared decision making between the patient and the provider. We always need to discuss everything and different options with patients and have them decide with us about the next most appropriate step. So I always try to follow an evidence-based approach when I make a decision, and I have a specialized AS clinic. So I only see AS on a day of the week. So we have everything is controlled. We have the study procedures. We have everything needed for us to do the best for our patients who have AS. So I try my best to make sure that there is no active inflammation, whether by checking labs, whether by checking, of course, physical exam is very important, by checking MRI of the SI joint and so on. I need to make sure that I did everything I could to control the inflammation because, of course, we do not want the disease to progress, we do not want damages to happen, and so on. So the first 6 months after treatment, after establishing care with me as a new patient who has not never been on medications for AS, I focus my first 6 months on controlling inflammation. Why is that? Because right now in 2025, we do not have the means to differentiate where is the pain coming from at this point in time. What we're working on in our research projects is to try to find a model that we can predict who will develop what type of pain, what phenotype of pain, so we can target it early on. This is now, of course, in the research, and we are trying to prove that hopefully in the near future. But right now, we need to focus first on the active inflammation because that can lead to actually organ damages and things like that. So, and before 6 months of being on active treatment for inflammation, it's very difficult to know if the inflammation is truly controlled or not. That's why I tell my patient the first 6 months are very, very, very important. So we treat inflammation for the first 6 months. If patients still have significant symptoms in the first 6 months, despite being on an active inflammatory agent, at this point, of course, NSAIDs and muscle relaxants and so on, of course, these are part of the algorithm in the absence of any contraindication. If they are still having active symptoms, I sometimes reach out to gabapentinoids such as gabapentin or pregabalin because there are some data not on ankylosing spondylitis, on different conditions, that these type of medications might help with the ascending pathway of the brain, of the nervous system.
Okay.
And then after 6 months, we talk again. Of course, in between, we'll be communicating if there is any need between the patient and myself. And then at 6 months, we will reevaluate. If everything is controlled, we are happy. That means controlling the inflammation is doing the trick. If they are still having active symptoms, at that point, I do a little bit more investigation to make sure that there is no active inflammation at that point. If there is no active inflammation, and I'm sure about that, at that point is when we target the descending pathway of the brain by usually by doing the serotonin norepinephrine reuptake inhibitors such as duloxetine. This have been shown in other, and again in other conditions, not in AS, but sometimes we extrapolate data from other conditions. At all time, regardless whether it's the first 6 months or later on, I like to work on this connection in the brain, the brain and the body. This is where I always recommend mindfulness, meditation, yoga, because there are some reports, again, not in AS, but in other conditions, that it might help with this connectivity in the brain between different regions. And it might reset some of the connectivity. Of course, we still need to replicate that in AS patients, but this is how I usually approach how to approach pain and axSpA. Briefly, of course.
No, that's awesome. And I think this brings a question of pain is something we talk about a lot, like uh, in my context to SAA, and I think about it a lot. And so many people are frustrated uh, when the treatments aren't working or fully removing the pain. What should they do with their provider?
Yep, they have all the right to be frustrated. You know, pain is something that is not pleasant. It's uncomfortable and it's painful. And I think the first thing that every provider should do is to acknowledge the symptoms of the patient. Because yes, there is symptom, even if we cannot pinpoint where it's coming from, we need to acknowledge that there is pain and our patients are having pain events and pain symptoms. Honestly, I ask patients to always think that there might be a solution. Cautious optimism, I like that, because there's always something going on in the literature and in the research world that might open a lot of doors for hope. But at the first step, the communication between the provider and the patient is the most important. Because from the first visit and second visit and third visit and so on, there should be expectations about what are we doing, what is our next step, and so on. And trust me, whenever patients understand what's going on, they they will feel better. I know the pain might not go away, but they will feel much better whenever they have a lot of understanding about the process, about what are we looking at right now and what's our next step. When they know that there is something that can be done, they will feel a little bit better. And again, the next step would be to look with the provider at trying to phenotype the pain and to look where it is coming from and to do a targeted approach at the pain based on where it's coming from to target that. Because trust me, if we're just doing blind treatment without targeting the cause, most patients will not feel better. And this is from
Right.
like, I've seen it a lot in the clinic.
And pain is different for everybody, right? Uh,
Yes.
Sometimes it feels like that. I call it hot sometimes, which is what I call inflammatory pain. Sometimes it's nerve pain. Sometimes it's all over your body. Uh, can this be identified by phenotyping the pain, or what's going on in that case?
Yes, yes, definitely. So I'm glad that you mentioned this. I have patients who have contacted me that I'm having a flare of my disease. Because, yes, if they have not heard about the different phenotypes, of course, the first thing will be I'm having a flare of the disease. But then by explaining, I always explain as much as I can to the patient. By explaining, most patients tell me, "Oh, thank you for explaining. Now I understand the difference between them." And they have expectations about when something happened because I have irradiation of symptoms because of a nerve versus an active inflammation. The experience of pain is very different between different patients and between individuals. And again, we need to acknowledge that and we need to work on it. But again, explaining what's going on to patients, it makes a big difference because they will know how to work with the pain symptom. At the beginning, everything will be new. Patients will be anxious, and they have the right to be anxious because this is something new to them. But we need to, again, just make sure that we know where it's coming from. And we tell the patient that, for example, based on what we did, I do not think I see, based on the workup we've done, I do not see anything that's life threatening. I do not see anything that's causing an organ damage and so on. This will make patients feel better about it. And then we will talk about targeting the pain by the different modalities that we have, whether it's pharmacologic by medications or non-pharmacologic by activity and so on, to get to a point where they are comfortable. And I think setting expectations, when patients set expectations for themselves, I think they will feel much better because if we are starting at a level of 9 out of 10, and our expectation will be to go to 0 out of 10, this might not be possible. And not only in axSpA, in a lot of different conditions in medicine.
Right.
So I always have like a goal with my patients. Let's try to lower it from 9 to 4 first, and this will be a great success. And then we will see how we can take care of the remaining pain. But setting this expectation, I think it helps patients a lot.
Yeah, I was just having this conversation with someone the other day, because I know so many people that are in pain all the time with this disease. And more recently, I had probably what I'd call the worst flare in 10 years. And while I generally have sort of learned to live with like a 2 to 3 on a daily basis, this was like a 9. And I really found I said to someone who works for me, I said, I forgot what this is like. And it just brings this like overwhelm of wanting to help people fix it, because it might be your arm that hurts, but it's preventing your whole body from doing what you want it to do. And it's it's interesting to hear you say, it's sort of like you can get from a 9 to a 4, and then that 4 to 3 is much, much harder, and 3 to 2 and 2 to 1. But you can live a good life if you can start lowering it more significantly, I imagine.
Yes, definitely.
Yeah.
The more we can lower it, the more the quality of life will be better. And our goal is for patients to live their life happily. They are able to do their daily activities or things they like as much as possible. So this is our goal, definitely. By lowering the pain numbers, of course, this will be patients will be able to do things they like, their quality of life will be much better, and so on. And that's our end point or ultimate goal from all our research we're doing is to improve the quality of life for our patients. And something you mentioned very important, Jill, is about acute or subacute pain. So there's a difference between the chronic pain that people can live with at level 3 or 4, and when it's all of a sudden goes up to 9. This is more of an acute. And this is what makes me, this is a little bit different from the chronic pain. This makes me think about there is something like an acute event that's happening that's driving the pain to go up to 9.
Hmm.
Is it a flare of the disease? It's possible. It's possible. Is it something else going on, such as a major life event? It's possible. Is it a fall that the patient had? Maybe an accident, maybe. But usually the acute pain is a little bit different because there might be something happening right now that's triggering it to go up. This is usually, of course, it's very unpleasant, it's very painful. But in most cases, acute pain is something that does not last for a long time and it gets better within a shorter period of time, of course, with the hope that whatever triggered it is detected. The one that's much more challenging is the chronic pain that will remains at a certain level and it does not go away. This is the one that we hope to be able to fix or at least understand more in the near future.
Yeah, I think, but that acute pain can become chronic, right? And that
Yes,
is
definitely.
so hard to think about living with
Exactly.
regularly when yeah.
Yeah, you're right. Acute. I just wanted to mention very briefly about this transition from acute to chronic pain. This is a very, very important phase that right now we do not fully understand. There is a study on inflammatory arthritis that showed it was done on peripheral arthritis, not on axial, like axial spondyloarthritis. It showed that the first 2 years since the onset of symptoms, for first of 2 years of diagnosis, is the highest risk for patients to move on to chronic pain is the first 2 years. So this brings us, of course, to detecting it super early to prevent it.
Yeah.
Think about axSpA patients, axial spondyloarthritis patients who have 6 or 7 or 8 years of delay in diagnosis. Their risk of moving from acute to chronic pain is much more than other patients, and hopefully we can do better about that.
Oh, yeah, I hope so. Uh, okay, let's talk about feeling pain doesn't always mean the inflammation is there. So does the brain remember when I'm thinking about childbirth, but does the brain remember pain when inflammation is gone?
I think so. I think that the brain, when the brain goes into a chronic or the body goes into a chronic pain state, I think the brain is fixating on the chronic pain state and it's remembering the pain, despite that the trigger is not there at this point. Why does this happen? This is something that's not known at this point. What is the point that triggers the brain from modulating the signal well to a point where it's not being able to modulate the signal, to inhibit it, and to fixate on it, and to remember the pain? I like the description. This transition from this phase to this phase, it's not known at this point. We think it happens early on, like within, as I said, probably within the first 2 years of the disease. But why does it happen? I think there is an interaction between the inflammation and the pain, like the immune system when it's active. I think it is stimulating or triggering the nervous system, leading to this. But of course, this is not proven. We need to work on it for the future. But yes, short answer, I think yes, the brain remembers it. And that's why it goes to a chronic from an acute to a chronic phase.
Okay, so let's talk about maybe some more uh, things we can do as practices in our lives to help manage it. So first, let's talk about stress, sleep, and well-being. How do they affect pain levels?
Very important question. Um, these are all intercorrelated together. Stress, fatigue, you mentioned fatigue before. It's very, very, very important. Sleep cycle and sleep disturbances, they all go hand in hand. And if you think about it, it's more of a cycle. If you are in pain, you cannot sleep well. If you cannot sleep well, your pain level is going up. Same if you are if there is a patient who is stressed or depressed, their pain is going to go up, and the pain is going to drive their stress level up because they're not able to do things like they like. So it is a cycle, and always in clinic, of course, I'm treating inflammation, but also I'm screening for anxiety, depression, stress, sleep, and helping patients get the help they need in that area. I always stress on the sleep and the psychologic factors as well, because if these are not controlled, the pain will not improve significantly. They will still have some level of pain. That's why we need to work on all these together. So we work on how to help sleep, how to help lessen stress in life, and so on, because we need a holistic approach for things. Only focusing, and this is something that I want to mention to my colleagues in rheumatology, that the field has been focusing a lot on inflammation for a long time. And we see all these amazing biologic treatments and targeted treatments. They are great and they help a lot with preventing progression. But we do not want to forget what matters a lot to the patient. And it might not be inflammatory in nature, such as sleep disturbance, anxiety, depression, and the chronic pain, and so on. We need to also fi- focus on these type of symptoms so that our patients get the best outcome.
That's a really good point. Uh, we do forget the patients. We're like these living, breathing organisms. And different things matter, right? I think, yeah, I think you're onto something because it's and there's I like that you most people talk about depression and less so about anxiety. I hear just across like my own, we won't call it research, but just my worldview of talking to people on AS and axSpA, the anxiety I think is something that digging into that. I always think about like depression is a bit about the past and anxiety is a lot about the future. Is my interpretation of it. But I think there is a lot of anxiety for people living with these diseases uh, that can probably contribute to the outcome and the pain in general, I think is what you're saying. And I think am I right to say that we as a population have a higher than normal uh, predisposition to anxiety and depression?
Um,
Or is that still up for debate?
as a general population, you mean?
As a population of the with the disease.
Yeah, with the disease. Yeah, I thought I don't know about the general population, but
No,
yes,
no, we
yes.
don't want to go there.
For population with axial spondylitis, yes, you are right. Actually, there are studies that have showed that depression, anxiety are more prevalent in patients who have axSpA compared to general population, for example, or I'm not sure compared to other conditions, but definitely it's higher. And it
Yeah,
is understandable because this is a chronic condition that starts earlier in life in most patients, or at least the symptoms start very early on, and then it continues with them for their whole life.
yeah,
It can cause major changes in their lives, and that can lead sometimes to depression, anxiety. Anxiety is very important. You said something, I like it about the future. It's about the future. I put myself in the patient's shoes. If I'm not a medical provider, if I'm having symptoms, I do not know where this symptom, where will it end, and how it will it be life threatening to me or no? I do not know because I'm not a medical provider. This
right.
can drive anxiety, and it's very understandable. So I always think about it when I get a message or a call from a patient about a symptom. I feel that yes, they need guidance because they don't know. And it's their right, they don't know. And here it's where my role is to help them, to tell them, Okay, thankfully, I don't think this is, for example, life-threatening, and this is the next step, and so on. This brings us back to communication, which is extremely important, and education. These can help a lot with anxiety and depression, I think.
Yeah, I agree. I think that is, for a lot of people, I think when you see a provider, see your rheumatologist, and they can almost mirror and understand what's going on and help you through the hard moments, because I think many people have had them. Uh, Having someone there who can respond is it's super helpful. And in a fashion, I think also the timeliness of communication with these diseases is really important to get more rapid feedback of like, I know the office is closed on a Friday at 4 o'clock, but I can't get off the floor. And to be able to hear back rapidly, I think is also probably has a huge impact on outcome of the pain continuing. Uh, and I'm coming from a place of having been there many times over the years. Okay, so let's keep going on strategies. What types of strategies can help retrain the brain's pathways? And how do patients and people living with the disease try this on their own at home?
Yep, I think we talked a little bit about this before. There are, and again, we talk about a lot of these treatments or strategies. A lot of them are extrapolated from other conditions, such as fibromyalgia, such as rheumatoid arthritis, osteoarthritis, and so on. Because sadly, in the field of axial spondyloarthritis, we don't have a lot that was done in this subject before, and hopefully we will work a lot on it in the near future. So there is the pharmacologic and non-pharmacologic. Pharmacologic, which is medications. Non-pharmacologic is like exercise, body, mind, and so on, that can be done either at home or with the help of a provider like physical therapist and so on. The easiest thing that can be done at home is meditation, mindfulness, body mind connection, and yoga. These things are easy. They for most people. It does not. It's inexpensive because it can be done at home, and there are studies that it can potentially disrupt the abnormal alterations in the connectivity in the brain. So I usually recommend this, and I think a lot of people feel better on it. I'm not saying it will 100% take it away, but a lot of people feel improved on it. So this is something that can help. I always recommend that patients see a physical therapist for a range of motion, for the different things, because being active, it increases endorphins in the brain, and these type of neurotransmitters in the brain, they can make the body feel better, and they can inhibit pain. So usually I ask patients to start with seeing physical therapy, and then they can do exercise on their own. Aquatic therapy in the pool, it's very
Yeah.
good, especially for the joints and so on. And then, of course, there is the pharmacologic component, which it's either gabapentin, duloxetine, pregabalin. These medications have been shown in other trials, in non-expat trials, to be helpful with the descending and ascending pathways. These are things that we usually consider. There is, I know you might ask me about these, but I'm going to talk about them, the cannabinoids or low dose naltrexone. We do not have data on these, and at least in axSpA, or I'm not aware that we have strong data in the rheumatology field or even in fibromyalgia field. I know some labs are studying these in research, but
Okay.
we have not had any data yet. And I've had patients who tried low dose naltrexone before. This is just observation. They've tried it from their primary provider or naturopathic doctor or so on. Some people say it helps, some people say it's not help. So it's a mixed experience. But again, this was not done in a clinical trial or so on. We need to know more about that. One thing I want to add is about the muscle relaxants. Muscle relaxants, it my experience from observation from clinic patients, a lot of patients feel better on it, at least symptomatically. It helps them when they have an acute symptom like active flare or so on, can help relax the muscles. Of course, in the absence of a contraindication, we do not want patients to fall and have fractures or things like that. There is recently approved medication for fibromyalgia, which is sublingual cyclobenzaprine. This is a muscle relaxant. It was approved by the FDA for fibromyalgia treatment. I have not seen it on axSpA patients yet, but we hope to see data on it in axSpA because this might be helpful for patients with axSpA.
Okay. And do each of those like low dose naltrexone, what is the, because I think it was originally for opioid use disorder, right?
Right.
What is the mechanism that it blocks?
This is amazing. I'm not sure about 100% the mechanism. I think it works on opioid receptors. It
Right.
used to be, as you said, it was done on opioid. I believe it was the dose that's used is different for opioid overdose and for chronic pain. This is more for low dose naltrexone. I think it acts a little bit differently on opioid receptors, but I'm not really sure because I'm not very well. I don't. My research is not in this area in specific, but I can read more about it. But the theory, which I heard from other pain researchers, is that they think it can disrupt the connection between the two areas in the brain, the default mode network and the salience network.
Back to the
Yeah.
beginning.
Back to the beginning. So this is one hypothesis that low dose networks might be helpful in. I don't think it was proven yet. I think it's still in studies.
That's so interesting. It fascinates me when they find like a really something that doesn't
Prevention.
seem to be connected application of a medication. Uh, okay, so we talked about physical activity. Are you a meditator? Do you meditate?
I try as much as I can. Do you?
I do. I try in the mornings. I do guided. I listen to a couple different ones, and one of them he talks often about pulling the mind out of the body. Is his sort of thing, and I find it works. I think it is. A few years ago, I used to travel a ton for work, and probably 5-ish years ago, I found that listening to a it's the same couple of meditations every morning when I wake up, and then I listen to like the same 5 songs on my phone. That to me that sets me for the day. And so, of course, I'm not perfect. I'm probably getting a B minus, but it sets the tone, and I think what we put in our ears, goes into our hearts and our heads and all those things.
Definitely.
Uh, but it is certainly a practice, not a perfect, as we like to say.
But it's better,
uh,
it's better than nothing. That's how I think about it. It's better than nothing. So you're doing great.
yeah, it is better than nothing, and I think like everyone else, we sort of feel better, and then you get off track. Um, and I've done a couple of also a couple of exercises in like a reset where I just go blitz it for 30 days on. Right now I'm blitzing blue zones in my life to try and get back on track. But I think these things make a difference, and we talked with Heidi Prather, who runs lifestyle medicine, last week at Hospital for Special Surgery, and she had talked about, which I think is really important for people to understand, is they did a large study across time on pre-surgical orthopedic surgery candidates, uh, and those that adopted a lot of the lifestyle medicine pillars had a 3-point lower reporting on the pain scale.
Wow, that's a 3 points. That's impressive.
It is
It's not
impressive.
something you see in a lot of studies, so that's impressive.
Yeah, I'll see if I can get my hands on it. I think I asked her for it. Uh,
Can you please share it
okay.
with me if you
Yeah,
get it?
that's what
Please
yeah,
share
I'll
it.
see if I can find it. It's really great. I think because I think there are things, and she points out sometimes, to your point earlier, I think about when you're talking about coming down on the pain scale, I think a lot about so in my career at one point I spent a lot of time in food factories, and we were always trying to get more efficiency. And it was the same thing but in reverse, where we'd try to go from, a 3 to a 7 in being efficient, and that wasn't so hard, but when you wanted to go from 7 to 7.1, it was really hard. And I think this is the same thing with pain, as you nip it a little bit at a time. And just hearing the way that some of the lifestyle medicine can come in and does actually have an impact is interesting. And her philosophy a bit on some of the things we do day to day, uh, you know, we get barraged with information about how to deal with pain, and how to, not necessarily from providers, but from Instagram and Facebook, and what is the right diet for all of us to be on, and she sort of broke it down for me, which was, food. Let's keep it simple, less processed, eat closer to what and I think that thinking about it in a simplistic way, because to our earlier discussion about anxiety and depression and stress, all the complication of trying to learn a new way to eat and a new way to live and a new way to do all these things, I think it has an impact. So I think if we can hack pain, all the better, right?
Right. Yeah. Exactly. Yeah, I think all these, if they might seem small points, like healthy lifestyle, diet, exercise, meditation, they might seem small, but at the end they add up, and hopefully they will cause the improvement in the pale scale further when we add
Yeah,
things up, differently. Yeah, of course, diet is a totally different thing that we will not talk a lot about now, but it is extremely important, like
yeah,
not eating processed food, eating healthy food, and so on. It can make a big difference, of course, helping with weight and helping with the body in general, which
yeah.
might affect the pain perception as well.
Yeah, and I think it's also, we can go down. We'll save that for another episode, because I know we're nearly at our time together. So, last question. Well, I have two. What about the work you do gives you the most hope for the future for people with this disease?
I really am very passionate about the work I'm doing right now, and all my work with axSpA. Honestly, all my career so far has been focused on axSpA, and I will continue to focus on it. It means a lot to me. But this means more because it's directly related to what patients want to see. Of course, this is very interesting to me as well. But when I see that a lot of patients get very excited to hear about something new in the field of pain in AXPA, like in ACR, for example. I spoke with multiple patient organizations who talked to me about my project and so on. To see a lot of interest that patients and patient organizations are having, this is a win, and this is a huge success. So this makes me more excited about the next step of it. We are working with a lot of unknowns, and it's fine to say I do not know, but it's always great to try to know what's going on and why we do not know. So this
Yeah,
is how I think about it. Of course, I'm trying to collaborate with important, amazing colleagues and collaborators in different institutions who work on pain research, not necessarily on AXPA, but I'm trying to get any new technologies, techniques, methods to study pain in AXPA. I'm willing to do it because I have a goal, which is to help our patients with AXPA.
yeah. Well, we need more of you. And really, I mean, it's been such a pleasure to watch your career unfold and your dedication to this patient population. We're really grateful for you. So thank you. And I think if there's one thing, what would be the most important thing you would want patients to take away from your research?
Thank you first, Jill. Thank you so much for having me. It's always a pleasure to talk to you, and I'm always happy to talk to you. Um, I want to tell patients that yes, pain can be frustrating, the condition can be frustrating, but we need to work together in order to feel better, to have a good quality of life, because there are lots of amazing things in life. We will not let AS to bring us down. We will work together on controlling, hopefully, AS and feeling much better. There is a lot of studies ongoing right now to hopefully understand chronic pain and why pain happens in axSpA patients. Think about it. Always tell my patients, think about before the year 2000, we had no treatments for AS.
Wow.
And between 2000 and 2025, we have amazing treatments that made a lot of improvement, including stopping the disease from progression or slowing it from progression, controlling the inflammation, and so on. Now, hopefully, the medicine is moving towards understanding the pain and how to control the pain. So I really hope that we will get there at some point. So I want them to know that we are working with them and for them. And the last thing I want to ask our patients is I would suggest and encourage them to work with providers on research, not only as research participants, but as research partners. Because nowadays, and I'm talking with SAA about it, for every research project I start, I like to get input from a patient about the study design, about how to implement, what is the study idea, how do we do it? Because whenever we have a patient, or what we call them, person with lived experience
Yep.
on the team, this will make the project much more successful, and it will lead to more answers that hopefully will translate to the best outcomes for our patients.
Yeah, agreed. That is, and it falls in line with better outcomes, which is a sense of purpose. So I would encourage it too. Thank you so much, and all the best for an amazing 2026. I'm sure we will see more of you.
Thank you so much. Very happy to see you, and hopefully I'll see you in 2026, and happy holidays.
Thank you.
SpondyCast was made possible by donations from the Spondylitis Association of America's individual members and our show's corporate sponsor, AbbVie. Since our founding in 1983, the Spondylitis Association of America has been the face, voice, and leading nationwide nonprofit educating, empowering, and advocating for people living with spondyloarthritis. Through our extensive work with patients, the medical community, and partners, we provide information and resources to help people impacted by the disease live better lives and champion research to find a cure.